taking a history with respect to the hip, just as we've done with the other joints in the body, the most important question is the mechanism of injury. After that, the location of pain is crucial. I ask my patients to take one finger and show me exactly where their pain is located. Remember, your patient's definition of hip may be entirely different from yours. There's the anterior, lateral, posterior, and even the medial areas of the joint. Specific conditions are common in specific age groups. For instance, in children, septic arthritis, avascular necrosis. In older people, degenerative hip disease, arthritis. Remember as well about radiation. A lot of my patients are worried that they've got arthritis. Ask them, does their pain radiate into their groin? Does the pain wake them at nighttime? If both answered yes, then yes, they may have arthritis. You need to confirm that with an x-ray. But if they only wake at night because they've rolled over onto their side, it may be just a simple trochanteric bursitis. Be specific. Get your patient to be specific as well. I like to divide the joint up into the areas that I've just mentioned when considering the things that may be involved in the injury. For instance, in the anterior aspect of the joint, the hip flexors, rectus femoris, iliopsoas may be involved. In the lateral aspect of the joint, tensor fasciae lata, the IT band may be involved. The posterior aspect of the joint, maybe the gluteals, maybe piriformis, and it may just be referred from the lumbar thoracic spine. And finally, on the medial aspect of the joint, don't forget the adductors. All of these areas can be victims of acute or chronic injuries. Be specific with the mechanism, pain qualities, and characteristics. Remember, the more specific you can be, the more complete you can be, the better off you'll be when you go into your physical examination. When we do the physical examination of the hip, it's a little more difficult for the observation aspect, basically just because of where the hip is located and the amount of clothing or coverage that the patient will have. So try to have your patient in shorts or at least in a gown. This way you can observe for any subtle abnormalities or imbalances in posture and as well any obvious abnormalities as a result of an injury. The other thing you want to look for is an abnormality in their gait, such as a Trendelenburg lurch. This is an assessment that looks specifically at the gluteus medius. What you'll see is an abnormal drop or weakness in the unsupported hip when a patient's walking. That will often indicate that there's a weakness in that supporting gluteus medius muscle. The next part of the physical examination of the hip will involve muscle range of motion and muscle-resisted testing. So let's start with hip flexion. The prime movers of hip flexion are rectus femoris and iliopsoas, the range of motion being approximately 130 degrees. Hip abduction is performed mostly through gluteus medius, and the normal range is about 45 degrees. In comparison to adduction, which is performed by pectineus and gracilis with a range of approximately 30 degrees. Hip internal rotation is performed mostly by gluteus minimus with a range of 45 degrees, and external rotation is performed by the obturator in the front and the piriformis in the back with a range of approximately 50 degrees. And the last part of range of motion of the hip involves hip extension. This is done primarily by the gluteus maximus and the hamstring muscles, the normal range being approximately 20 degrees. So after you've completed the passive range of motion, now it's time to do resisted muscle testing. It's the same muscle groups. Just remember not to take the muscles right into full range. You want to test them at a little bit of disadvantage with respect to their mechanics. So bring them somewhere between 50% of their range and 75% of the range. So for flexion, place your hands around the top of the knee and ask your patient to pull their knee right into their chest while you pull back with gentle traction. Watch your patient for signs of pain and certainly ask them if that reproduces the pain that they've been experiencing. can do this really easily with the patient sitting right on the side of the bed. For instance, resisted hip flexion is simply performed by placing the hand over the top of the knee and having the patient push up. Hip extension is tested by supporting the lower leg above the ankle and having the patient extend their leg. Hip abduction, or abduction, is performed by the patient externally rotating their hips while you resist. And adduction is performed in the opposite way with your hands on the inside of the knees, resisting while the patient adducts their hip. If your patient is experiencing anterior hip pain, a test that's really useful is called the Modified Thomas test. Now, this test helps to differentiate between the pain coming from either the rectus femoris or the iliopsoas. Remember, they're both hip flexors, and they both cross the joint at the hip, but only the rectus femoris crosses the joint at the knee level. So, ask your patient to sit right at the very edge of the examination table, have them grasp the unaffected knee, and roll themselves gently onto their back. At this point, you want to make note of the angle of the knee and then of the relaxed lower leg. You'll notice with Serena that her foot actually is a little bit externally rotated. That indicates that her iliotibial band is actually a little too tight. The angle is actually quite good. Her leg is not sitting too high up off the edge of the table, so her anterior hip flexors are not overly tight. Now, the next step is to see if it elicits pain by simply pushing down over the top of the knee and seeing if that reproduces the pain your patient has come to see you about. If it does, the final step is to passively lower down the lower leg to see if that reproduces even more discomfort. This is the test that distinguishes between the psoas and the rectus femoris as far as the origin of your pain. The final aspect of the examination of the hip involves direct palpation of both bony and soft tissue areas. Where I'm going to start is anteriorly, with the anterior superior iliac spine, which is the most obvious to find. Move down to the anterior inferior iliac spine, where there's the insertion of the rectus femoris. From there, you can move medially, always warning your patient you're doing so, over to the pubic rami. Here, there's the insertion of the hip adductors. On the lateral aspect of the hip, you'll find structures like the tensor fascia lata, which starts up at the iliac crest and continues down to the trochanteric area. The greater trochanter is an important area for trochanteric bursal inflammation. Just behind the greater trochanter is the insertion of the piriformis, an area that's commonly inflamed and sore. If you follow down inferiorly from the greater trochanter, you'll follow the tract of the iliotibial band, a very common structure that's inflamed in runners and walkers. The last part of the hip examination involves palpation of the structures in the posterior aspect. The gluteus maximus and medius structures are found here, as well as an important muscle called the piriformis muscle. This is a muscle that runs obliquely across the buttocks and inserts into the posterior aspect of the greater trochanter. There's a condition called pseudosciatica, where the piriformis muscle is tight, and when it's tested or palpated, it gives signs and symptoms similar to having a disc herniation with sciatic nerve irritation. The difference is that you'll have a normal neurological examination. So if your patient is complaining of symptoms of sciatica, make sure you check the neurological examination, and also make sure you do the resisted piriformis testing as we did in the lumbar examination, and palpate directly over that piriformis muscle. The last thing that we would do here is check the hamstrings and the gluteal muscles as we did in the lumbar examination. You can also palpate the lumbar spine and the lower lumbar structures such as the PSIS as we did in the lumbar examination.